afternoon, and I'd like to thank the organizer for the invitation to present. All right, so I live in Tampa, Florida, so that means I know a lot about quality of life. All right, these are my disclosures. This is a patient of mine who is 69 and was diagnosed with standard risk myeloma, ISS1. In 2014, he received induction therapy, transplant, and was on maintenance therapy with lenalidomide. After a few years, he was in complete response, and he decided to discontinue it because of issues pertaining to diarrhea and fatigue. And as you can see, he started to have some biochemical progression. He lives about a few hours from Moffitt, and you know, it was for him important to try to be on an oral regimen, although he doesn't really also want to compromise efficacy. And he likes to travel, and you know, the question is, can we use quality of life data to try to decide when to start therapy for biochemical progression? And there's a number of regimens that we could consider in this situation, and can we use quality of life data to perhaps figure out what makes sense for this particular patient? And the disclaimer is I don't really have the answer to that. And quality of life, in one another disclaimer, is a little bit of an obscure concept. And you know, to the extent that this author mentioned that we don't really know what we're talking about when we're talking about quality of life. So that's really where I'm going to start. So the WHO defines this, by the way, as an individual perception of their position in life in the context of their culture, value system, and in relations to their goals and expectations. So it's something that is obviously very subjective, and the individual is going to be the most suitable to judge this. It's multidimensional and all-encompassing. And we may have developed a lot of different tools to measure in general what quality of life might be, although we may be very off in what the patient's really thinking. And on the other hand, health-related quality of life is a concept that involves all aspects of quality of life that are influenced by the health status of the patients. And these are psychological, physical, as well as social aspects. And we can measure that. Obviously very relevant in myeloma, because we consider that the disease is generally not very curable, that the patient demographic is very susceptible to this, and there's increasing costs of care that impact, obviously, quality of life, and there's access to specialists are also increasing the socioeconomic burden. So, of course, patient-reported outcome, you all understand. A global health score is actually one of the metrics used in the most popular tool that we use is the EORTC QLQ-C30 measure. The concept of MID is important to define, and I think it's one of the ways to look at it is a minimal, clinically meaningful, positive or negative change that can be perceived by a patient. So, for example, if you look at a global health score, is a global health score difference of 2 or 3 points, is that clinically meaningful, or is this just basically the same? And then, a lot of methodology would look at how do you interpret those results, and a lot of those studies have not been uniform in reporting things like MID or looking at mixed model analysis to try to assess quality of life longitudinally. I looked at this in terms of, in orange, the number of myeloma publications in the past basically 20 years, and looking at, each 5-year age group, each 5-year groups. And you look at myeloma publications that have to do with quality of life, and it's a bit hard to see, but the numbers are very small. So if you look at the past 5 years, while there has been an increasing impact or interest in quality of life, the number of research publications related to it remains low. This is an interesting study that kind of led to the development of the FACT questionnaire, and it's very telling because the literature reviewed identified 52 items to include, and they interviewed physicians and patients. And what physician ranked the highest of importance to them was pain and fatigue. What the patients ranked highest to them was sexual function and uncertainty about health. So in other words, I don't know about you, but I'm in clinic. I'm not talking with my patients a lot about sexual function. Perhaps because I don't want to, perhaps because they don't want to, perhaps it's mutual. But that's at the end of the day maybe what matters the most to patients. The MD Anderson symptom inventory actually is mostly been developed in the context of transplant. It's been validated against other EORTC scales, and mostly relates, if you can look at this list, on symptoms that are most relevant to the setting of transplant. There is a very small 6-question module that has to do with psychosocial and socioeconomic factors. This tool is the most commonly used, the QLQM MY20. It started out as a 24-question scale, but it was trimmed down to 20 questions. And if you look at this, actually, a large number of those questions have to do with symptoms and side effect. And at the end, it has to do with body image, future, and perspective. And so, again, not a lot of emphasis on socioeconomic factor or psychological factor. This scale was developed in the UK and actually looked at patients outside the setting of a trial. It's hard to read, but a different, there is a symptom-based score, and then there is actually quality of life and palliative care-based score with an emphasis on a healthcare support and whether the healthcare understands the patient problems. Moving on now to studies that have looked at health-related quality of life as an endpoint. These are newly diagnosed randomized trials that have looked at that. The list is a bit longer, but I tried to summarize it in those. The HOVON study looked at MPT versus MP, and while generally there was an improvement with treatment in the global health score, thalidomide did result in toxicity that were obvious on quality of life assessments. When you look at the 2 next studies, the VISTA study and the upfront studies, they have some similarities in common in that there was a transient deterioration of quality of life in the initial part of therapy. And when the bortezomib treatment was given less frequently, the quality of life generally improved. And when you look at lenalidomide-based inductions and the MM015 and the first study, those studies have generally found that there's been an improvement in quality of life from baseline in all scores in general. And a particular interest relates to lenalidomide maintenance, which we'll come back to in the MM15 study. Lenalidomide maintenance did not result in more side effects from treatment. We're looking at patient-reported outcome measures. And importantly, it had a more frequent improvement in this minimal important difference compared to patients who discontinued therapy with MP or MPR. How about transplant? How does it impact quality of life? And there is very little data that are randomized data in this setting. A lot of the transplant literature suggests that there is an impairment in health-related quality of life in the initial period, but it rebounds around the 1 to 2 months after transplant. That's a typical recovery time. Some predictors of who has the most impact on their post-transplant symptoms actually was pre-transplant scores. So female gender and prolonged time from diagnosis to transplant, underscoring the point that early transplantation is probably more beneficial if you're looking at quality of life. Outpatient versus inpatient transplant, I always had the bias that outpatient transplant was easier. It turns out it's easier for patient on some respect. In terms of the social well-being, it is definitely easier. In terms of the physical well-being, it turns out to be a little bit worse. How about maintenance therapy? The CALGB and IFM study didn't look at quality of life in terms of the maintenance lenalidomide data. The MM15 study looked at patients who were over the age of 65, but yet still looked at maintenance lenalidomide. And this study by Dr. Abunauer from Indiana looked at the CONNECT MYELOMA database, so it's a non-study population that's mostly community-based, and noted no differences in quality of life score in patients who received any maintenance or len maintenance compared to either no maintenance or or non-land maintenance. And in fact, some of the quality of life scores seem to decline right before progression events occur. In terms of the relapsed refractory setting, this is some of the studies that have looked at health-related quality of life in this setting. The APEX study, the MMO3 pomalidomide study, carfilzomib ASPIRE study, tourmaline and ELOQUENT are listed here. The list is longer. In general, if you want to summarize this, one can say that there seems to be a greater time to worsening of quality of life with effective therapy, with one of the novel agents, for example. Of note, for example, the ASPIRE study was very novel in that a 3-drug regimen was shown to have improvement of health-related quality of life, GHS scores, for example, compared to a 2-drug regimen. So while the therapy may be more intensive, it's nevertheless resulted in better quality of life. The tourmaline study is perhaps the only double-blind study among those, and showed in reality there was very similar global health scores. However, there was a better physical and emotional functioning with the ixazomib arm, but worse diarrhea. And the ELOQUENT study showed no difference in health-related quality of life between the two arms in reality, also suggesting that the addition of a third drug, a novel drug in this case, did not worsen quality of life. Can we predict what impacts the most, health-related quality of life? And this is a sub-analysis of the MM15 study. It turns out that female gender, advanced age, and progressive disease all negatively affect this. On the other hand, achieving VGPR or better, but not achieving PR. For example, PR patients compared to stable disease did not derive improvement in quality of life. And while anemia is associated with worsening quality of life, neutropenia did not. So when you think about some of the toxicities that we may be encountering, some of them may not cause as much impact on quality of life as others. Other factors that could affect quality of life include different studies have looked at different measures, but in general, for each additional year with myeloma, the GHS decreased by 1 point, and this is an older study looking at more conventional therapy. Receiving any type of therapy within 30 days decreased the GHS score by about 9.5 points. A treatment-free interval turns out to be something that patients value very much. And obviously a longer treatment-free interval was associated with better quality of life measures. So can we go beyond symptoms and signs of the disease? And we've conducted this study where we've looked at literature review, phone interviews with patients and physicians, but we also try to look at this in a qualitative way. And so when we ask patients some questions, what bothers you the most? And sometimes one of the answers could be something that surprises us, and things like the impact of clinic visit for some patients was a burden, whereas for most was not. The use of an IV drug, for example, even IV bisphosphonate, could be something that was a very detrimental factor in some patients. And then if we try to model it, and we can try to tell that there's many things that impact the patient's health-related quality of life, including obviously comorbidities, the disease, the side effects from treatment, but also socioeconomic factors such as inconvenience, financial problems, mode of administration of treatment, the time frequency of monitoring. I think there's a lot of gaps in the literature in this area. A lot of the studies don't have uniform ways to look at the measures, and as a result, comparing across trials can be very difficult. There is very limited data outside of the setting of clinical trials, and the impact of socioeconomic factor is very much lagging behind. In terms of cost and affordability, Dr. Rajkumar is going to talk about, can we afford all those improvements in therapies is something that is going to be very important. And then can we anticipate changes similar to the patient we presented earlier, where can we anticipate what makes the most sense for a particular patient profile based on what they value the most? And I think this is still an area where we're not particularly good at. So in summary, despite the fact that Myeloma is considered generally incurable. There's still a little bit of data on the impact of health-related quality of life. In general, this mirrors the disease course. It seems that what we consider a good response, in some cases, for example, PR, may not be very impactful and very much associated with good quality of life, but VGPR and better, on the other hand, does improve quality of life. And it does refer to more than just signs and symptoms, and the socioeconomic parts are actually not well developed. We should look at this in the real world, not just for patients on trial, which represent a selected group of patients who have agreed to participate in trials and go the extra effort of traveling to cancer centers. I'm going to stop here. Thank you for your attention. This is where I work. This is the clinical team I work with, but really my best quality of life is about an hour south of Tampa. It's Ana Maria Island, and it truly looks like this. So thank you for your attention.